Sir, we are live now. With all your permission, I'm starting this session.
Okay.
A very good afternoon to everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Murugan Shankarnatham, sir. Sir is a former professor, Department of Dermatology and Venerology, Sri Mombika Institute of Medical Science, Kusakeram, Kanyakumari District, Tamil Nadu. Presently senior consultant in HIV and sexual medicine, Tirunelveli, Tamil Nadu, and former national president of Indian Association for the Study of Sexuality Transmitted Disease and AIDS, that is IASSTD and AIDS. Today he is going to speak on a topic: skin is the mirror of many diseases as well in HIV. Let me tell you overview of the topic. HIV can manifest in various dermatological ways, ranging from non-specific rashes to opportunistic infectious and malignancies. Skin issues can signal immune system weakening, promoting early HIV detection and management. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed.
Thank you, Faraz, for a nice introduction. Good afternoon, everybody. It's my pleasure to meet you all on this platform. And today, my topic is, as Faraz explained, skin is the mirror of systemic diseases. Yes, of course, we all knew that anemia, jaundice, and many skin, that is cyanosis, clubbing, petechiae, ecchymosis, purpura, spider neve, so many signs will lead you to diagnose the systemic disease. Like that, the HIV infection also, everyone will have some sort of manifestation. Many times, this will lead to the diagnosis of HIV or suspicion of HIV infection. Sorry, my slides are, yes. Yes. The skin and mucous membrane are the largest organ of our body. It's the elevation of our body structure. Varieties of systemic diseases like anemia, jaundice, diabetes mellitus, autoimmune disorders, endocrinopathies, chronic kidney disease can be diagnosed in many occasions just with mucocutaneous symptoms or suspicion. Index of suspicion is created by the skin and mucocutaneous manifestations. Likewise, peculiar mucocutaneous manifestation will lead to the suspicion of HIV infections also. So that is very important, and today's topic I'm going to cover some of the things. Let us go to the topic. A wide range of mucocutaneous manifestation can occur in HIV disease per se, and also due to various opportunistic infections according to the immune status of the individual, which is grossly varying, fluctuating during the course of disease. Oral lesions plays an important role in the suspicion of HIV infection in the early stages onwards. Normal skin diseases behaves differently in the presence of AIDS. A wide range of opportunistic infections, bacterial, viral, fungal, protozoal, and parasitic, can also cause wide spectrum of manifestation in these individuals. How skin got affected in HIV disease? Due to the chronicity and sequelae of HIV infection itself. This itself, because of running long course, chronic wasting, ichthyosis, pigmentation can occur due to various opportunistic infections. It may be fungal infection, histoplasmosis, CRYPTOCOCCUS, or viral infection, cytomegalovirus infection, or so many other things peculiar to HIV infections can cause skin manifestations. Altered behavior or exacerbation of the ordinary skin diseases and disease due to comorbidity. Skin disease can occur to anybody. Psoriasis, lichen planus, pemphigus, pemphigoid. So all these things in the presence of HIV, it will have an exacerbation different behavior. And also, the manifestation to the comorbidity also sometimes exaggerated or differently. Like, so all these things we have to keep it in mind. Another thing is altered immunological reaction. Normally, in HIV, the CMI is impaired, will be impaired. The thing is going to be suffered because of the disease progression. So during the suppression of the CMI, human immunity sometimes may cause an exacerbated reaction. So this is how the patient may develop some pruritic papules, papular urticaria, or autoimmune disorders. So all these things can happen. Let us see some of the lesions. Possible opportunistic infections in India could be due to bacterial. Even tuberculosis, skin tuberculosis are there. So respiratory infections due to CMV or other things also can produce skin lesions. Bacterial enteric infection, atypical mycobacteriosis, herpes simplex virus, oral leukoplakia, herpes zoster, varicella zoster, cytomegalovirus infection, human herpes type infection, human papilloma virus, and candidiasis, cryptococcosis, penicillosis, histoplasmosis, aspergillosis, pneumocystis, cerevisiae. All these things can occur as an opportunistic infection in the presence of HIV because of the fluctuating immune condition. Parasitic cryptosporidiasis, microsporidiasis, giardiasis, strangulodiasis, toxoplasmosis, and other illness like AIDS, dementia, invasive cervical cancer, non-Hodgkin's lymphoma, KAPOSIS, sarcoma, etc. Now, let us go into the oral manifestation initially before going to the skin manifestation, which is the early manifestation and makes one doubt whether the patient is having HIV infection or not. So this is oral hairy leukoplakia. You can see this on the lateral border of the tongue on both sides. You can see some glistening corrugations on the lateral aspect. See, so this is a shining whitish corrugations. So this is like that. So this is called as oral hairy leukoplakia. This is mainly occurring in, even we can say, unique to HIV infection. This is supposed caused by Epstein-Barr virus. But usually what happens, it is a asymptomatic one. It doesn't need any treatment. When the patient's immunity rises, goes up, the lesions will disappear. So it doesn't warrant much treatment, any treatment, but otherwise it gives a clue. You can suspect the presence of HIV infection. Of course, oral thrush. So some patient may have both oral thrush and OHL, that is oral hairy leukoplakia. You can see here, this patient is having extensive oral thrush and he is having oral hairy leukoplakia. So this is double manifestations, definitely gives a clue for HIV, presence of HIV infection. And oral thrush. Oral thrush can occur even before HIV era. It is more common in bedridden and patients on cytotoxic drugs or very ill patients. But here, young adults, not much of illness, ambulant patient may develop oral thrush. So when you see in young people oral thrush, you have to suspect, could it be a case of HIV infection? See, it is severe form of oral thrush. Both buccal mucosa, tongue, and lip angular stomatitis, everything is there affected. So this is a very much characteristic for HIV infection. Usually, oral thrush will occur in the early stage. Normally, the CD4 count will be around 700 to 1200. When it's going below 350, the patient may manifest. Oral thrush can occur. But candidal esophagitis is one of the indication the patient is advanced disease, opportunistic infection. So here we can see extensive candidiasis through endoscopy. We are seeing it through endoscopy. So this is a patient is having extensive candidiasis, esophageal candidiasis. The patient will have difficulty in swallowing, deglutition. That is very important. And herpes simplex infection. Nearly 40 to 50% of any population all over the world will be likely to be having herpes simplex 1 antibodies. Almost every one of us, many of us would have come across herpes simplex infection. And it's a self-limiting disease. Even it may persist for 1 week to 10 days or 14 days, the primary episode, and subsequent recurrences are very common. During recurrence, it will not persist more than a week. So in a patient who is having this herpes lesion, persists for more than a month, then it could be a case of HIV infection. So this is another clue. Herpes simplex infection. It may cause sometimes CHEILITIS also. So if it is left, that is, if it is not suspected HIV infection or something, it is not interfering, it may persist for months together and may go for like this growth like thing. So this is a herpes simplex infection, type 1. So the type 1 is causing herpes labialis or nasolabial region, mainly the oral and nasolabial region. Whereas HSV2, herpes plus type 2, is mostly causing genital herpes. So this is another case of necrotizing cheilitis. It may be due to secondary infection or phagocytic infection like Borrelia vincenti or Borrelia balanitis, like that. So this patient, if you see, this patient is having oral thrush and also she is having facial palsy. You can see the left eye closed and the right eye is not able to, she is not able to close it. And deviation of the mouth and tongue. So it's a case of facial palsy. All gives clue. These cases maybe you have to suspect HIV. Regarding the skin manifestations, the patient may have papuloscomus disorders, non-infectious pruritic disorder, hair and nail changes, vasculitis, photosensitive reaction, pigment disorders, which can occur to anybody. Seborrheic dermatitis, psoriasis, Writer's disease, generalized cirrhosis, insect bite, papular pruritic eruptions, eosinophilic folliculitis, hair and nail changes, polyarteritis nodosa, vasculitis, leucoclastic vasculitis. I have seen recently, not seen, I have come across a case as a reviewer. The case, the patient was having HIV and systemic sclerosis, scleroderma together, and photosensitive reaction, ultraviolet hypersensitivity, porphyria cutaneous, chronic actinic dermatitis, pigmented disorders, hyperpigmentation, vitiligo. All things can occur in HIV with an exacerbated pattern or altered pattern. Tumors like that, squamous or basal cell carcinoma, it's not uncommon. Others like multiple dysplastic nevi and melanoma, non-Hodgkin's lymphoma, T-cell lymphoma, cutaneous T-cell lymphoma, and malt lymphomas, this B-cell lymphomas, and KAPOSIS sarcoma. So once again, presence of KAPOSIS sarcoma is unique. Even the person, that is when the HIV was diagnosed or suspected in 1980-81, the KAPOSIS sarcoma is one of the tumors which predicts. Fortunately, in our country, it's not so common, but in homosexuals in other countries, KAPOSIS sarcoma is very common. Pre-antibiotic era, pre-AIDS era, the KAPOSIS sarcoma can occur in Japanese people and Middle East people, but it is a slow progressing, mainly leg and ankle, around ankle. But during AIDS era, it can occur anywhere in the body, even the viscera, inside the viscera. Now, we will see certain pattern of HIV, there is skin dermatosis. So this is, you can see pruritic papules and scars over the outer aspect of the limbs, upper limb and lower limb. So this is very common in most of the patients, even the early stage and late stage. It is an exacerbation reaction of humoral immunity to insect bite, mosquito bite. This is an exacerbated reaction due to humoral immunity due to mosquito bite. So this is one of the commonest things. It can occur even many children, many people, but in adults, when they have HIV, it is one of the commonest features. And nail infections, skin infections, candidiasis, dermatophytes are not uncommon, and it will have severe form and involving all the nails, and you can see in the inner aspect of thigh. Candidiasis, you will have, it will not be having definite border like the dermatophytes, but it will have satellite lesions. So this is a candidiasis. So tinea pedis, you can see the nails totally involved. So candidiasis in the intertriginous area, axilla, severe form. Intertriginous area, inframammary region, and also mammary region. You can see the classical satellite lesion and reddish. So this is a classical lesion of candidiasis. So this is a intertrigo over the digits. This could be due to eczema, dermatophyte or dermatophyte. So we have to watch, or even you can test either with the patch test or with the skin scraping for fungus, and we can treat accordingly. Tinea cruris, otherwise called as chalk itch or dovey itch. So this will have a definite, well-defined border, spreading border. So this presence of this border is indicative of the tinea cruris. So it can in the groin region, also in the gluteal or perineal region. Severe form of tinea pedis, athlete foot. You can see that they are well-defined borders. So this is tinea pedis. Even tinea versicolor or pityriasis versicolor. So this is also florid and sometimes may mimic erythrosma. And herpes zoster. As I told already, the herpes simplex persisting for more than a month, we can suspect HIV infection. Like similarly, the presence of herpes zoster can occur to anybody. So in adult, if it's occurring, you have to suspect HIV, especially when it is multidermatomal, especially when it is multidermatomal, and also usually it is a unidermatomal, and also when it is occurring bilaterally, or when there is a recurrence. Usually herpes zoster will not recur. Once it comes, it has a resistance, high resistance. Whereas in HIV infection, it may recur. So the recurrence and the multidermatomal pattern, if you happen to come across the herpes zoster, it could be a case of HIV, and you have to test for HIV and confirm. So this is the message I want to give. And ichthyosis, xerosis is common. In even ichthyosis can occur congenitally or some diseases, diabetes mellitus, Hansen's disease, myxedema, so many other things also, even kidney diseases. But here also it can occur. So here you can see this patient is having warts, viral wart, VERUCA vulgaris, multiple lesion throughout the face. You can see. So this is VERUCA vulgaris in a HIV patient, usually in advanced stage. And in such case, when you are instituting ART, and when the patient gains immunity after some time, usually when the ART is appropriate, within 24 weeks, it will become less than 400 viral load, and in another 40 weeks, it will be undetectable. So when it is viral load undetectable, when the immunity gains more than 500, it automatically it will go sometime. Otherwise, we can treat. So this is a genital warts in a HIV patient. So these are all very, very common and exacerbated. That is very important. Syphilis. Almost all the STDs and HIV with a single episode intercourse, one can get HIV at the same time STD. If you happen to see any STD, you have to rule out other STDs and HIV. If you happen to HIV, screen the patient for other STIs. That is very important. You have to keep it the message. And here in HIV, the syphilis occur, it behaves differently. This is a malignant syphilis or Luis maligna, and you can see the lesions are very prominent, very big, and necrotic pustular lesions, and you can see. So this is Corimbos type of lesion, and palmar lesion, plantar lesions are there. So this is a very severe form. And one more thing is, in the presence of HIV, the patient may go for meningitis, early precocious tertiary, all these things happen. And serology also will behave differently, late manifestations, and once positive will persist forever. All these things can happen with syphilis. So seborrheic dermatitis, normal seborrheic dermatitis, it may exacerbate in the presence of HIV. See his face. And CRYPTOCOCCUS is a protozoa. It can produce meningitis. It can produce respiratory tract infection. It may produce skin infections also. The skin infections due to CRYPTOCOCCUS mimics like that of molluscum contagiosum. You can see the lesions like molluscum contagiosum. The face. This is a mucocutaneous membrane lesion, severe form of cryptococcosis. And this patient is also having lesions. So you can see the papular lesions, cryptococcosis. Cryptococcosis lesion. Cryptococcus neoformans lesion. And another Another fungal, sorry, cryptococcus is also fungal infection. Sorry, not protozoa. Sorry, I mentioned it's a fungal infection. Penicillium morphineri is also a fungal infection. And this Penicillium morphineri is more common in eastern provinces. Assam, Meghalaya, Mizoram, Manipur. In those areas, it's common. When the patient hails from that, when they went there and come, they may likely to have, you may have to suspect penicillosis. Molluscum contagiosum in a CLHIV. CLHIV means child living with HIV. Child living with HIV. You can see the group multiple lesions and size and all. So this is, but mostly they may regress with the ART treatment, regular treatment after gaining the immunity. Or sometimes we have to interfere with needling or 5% KOH application. So once again, molluscum contagiosum in HIV patient. See scrotum and genitals, the patient, penis, skin. So it's a case of molluscum contagiosum. Molluscum contagiosum in a woman over her external genitals and thigh region. Scabies. Scabies can occur to anybody, but Norwegian scabies. Previously, we used to say in the mentally ill patient and a mentally retarded patient, Norwegian scabies is more common. But here in HIV, these patients may have extensive scaly lesions, intense, and this is a Norwegian scabies in a HIV patient. And psoriasis also exacerbated in the presence of HIV, especially normal distribution, mostly it is a extension distribution, whereas in HIV, it is many cases may be having flexural psoriasis. Now this is Kaposis sarcoma. You can see the tumor growth, swelling, brownish or reddish or purplish in color, oral cavity and also in the arm. So this is a case of Kaposis sarcoma. So when you suspect Kaposis sarcoma, you have to go for biopsy. Biopsy will prove the Kaposis sarcoma. The presence of hemocysteine pigment, extravasation of the RBCs and other features like parakeratosis will confirm the Kaposis sarcoma. It is a tumor arising from the vessel, blood vessels and lymph vessel walls. So Kaposis sarcoma. But fortunately, it responds well to the cytotoxic drugs and radiation. And when the patient gains immunity also, it will do good. So genital herpes and other herpes. As I told already, it's a self-limiting disease characteristic with vesicles, erythema, and the vesicles will rupture and gives rise to multiple group tiny ulcers. So this is normal thing. It's a normal individual. In the presence of HIV, it may persist for more than a month. It may go for, it coalesces together to form, it behaves funnily. See, this is the extensive ulcer. Nobody can suspect HSV in a normal individual or if when you see first time. So when you are handling a HIV patient, you have to suspect the possibility, could it be due to HSV? And this is thing, and whitlow in the fingers, in the oral cavity also it can occur. So once again, the genital herpes behaves differently, and the ulcers may look like granulomatous ulcer or sometimes even septic ulcer. See, so this is a extensive ulcer, and because of chronicity, these ulcers coalesce together and form a big ulcer. So this patient having some papular, like that is hydradenitis suppurativa like picture was there. But HIV patient, the patient was responding to acyclovir wonderfully. After treatment, improved a lot. So this is a case of normally tiny group ulcers will be there. So here you can see punch out ulcer, big ulcer. So these are all alternate behavior, and we have to have a high index of suspicion in a case of HIV individual. So this is another case, HIV patient having extensive. So see here the borders are highly irregular. So this is once again indicative of HIV, HSV. Whereas in syphilis or granulomanguinal, the borders will not be so irregular, serrated edges will not be there. So this is another case of HIV and HSV, herpes simplex. So this is another case of, so looks like granulomatous, granulomanguinal, but it's a case of HSV. And so this patient, a combination of herpes simplex infection, see, you can see oral lesions and lip lesions and CRYPTOCOCCUS lesions elsewhere. You can see CRYPTOCOCCUS lesions and oral thrush, all put together the patient is having. Here, as I told already, because the CMA is suppressed, the patient may have exacerbated humoral response. So this is the drug rash, Stevens-Johnson syndrome. They also will be more common, exaggerated. Even antiretroviral drugs like nevirapine can cause. That is, prophylactic, that is Septron and sulfur drugs can cause, or other drugs can cause. And so all these things can occur. And this is a case of tumor in a PLHV. So all types of tumors are more vulnerable because of the altered immunity, especially intraepithelial carcinoma of the vulva, VAN, intraepithelial carcinoma of the anus, intraepithelial carcinoma of the cervix, all can occur, but it's a case of squamous cell carcinoma, and this patient refused for treatment. And one more thing is, the patient may like to go for pigmentary changes also. More wasting is there, but wasting, they cannot say is a skin manifestation, but it's also we are seeing externally. And apart from the wasting, most of the patients will have some peculiar hyperpigmented skin. So this is also characteristic for HIV. So this patient is having extensive wasting, we can see. And one more thing we have to remember is pigmentation due to treatment. We can see brownish lines, blackish line or brownish lines, sometimes violaceous, purplish lines will be there. This is due to zidovudine drug, zidovudine toxicity. The patient is also having a bluish color tongue in the tongue. So this is, but it's not a thing to be worried, but sometimes patient may be worried. So these are the various types of manifestations, few manifestations, many more manifestations can also occur, and we have to have a high index of suspicion to suspect HIV when the patient are being treated. Now the present dictum is treat all as soon as you had diagnosed. So most of the cases previously, so most of the cases I have shown is are advanced cases. Nowadays, patients are not coming so commonly in the advanced stage, because now the trend is treat all. As soon as diagnosed, you have to start the treatment. So when the patient's immunity rises, most of the lesions will go automatically. So these are the things you have to keep it in mind when you are handling a HIV infection. And this will be very important message for all the dermatologists. Thank you very much. Stop HIV, take the medicine regularly, and protect yourself with a condom. Thank you very much.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us. It was a wonderful presentation from your end, sir. I hope that all the participants are going to apply this knowledge on their practice also. Sir, I can see, sir, we have received some questions from the participant end. If you allow, with all your permission, can we take this question, sir?
Yes, it will be my pleasure.
Yes, sir. Great, sir. Thank you so much, sir, for allowing us. The first question is from Dr. Agarwal. He is asking, what are the possible cutaneous complication of herpes simplex and herpes zoster virus in HIV disease?
I told already. The thing is, herpes zoster, herpes simplex is a persisting disease, not a self-limiting disease. Unless you intervene, it will not heal automatically. And usually, when it is occurring in the eye region, it will have complications like blindness. Otherwise, when we diagnose it, it will be treatable, and persisting for more than a month, you have to suspect. Regarding the herpes zoster, it will run a florid manifestation, florid course, and multidermatomal and recurrences are more common, which is not in the case of normal people. So that is also we have to keep it in mind. And sometimes when it is involving the facial nerve and facial palsies and other things are also very common with the herpes zoster.
Thank you so much, sir, for explaining it really well, sir. I can see there are a few more questions, sir. Another question from Dr. Shubhangi. She's asking, how are HSV and HZV treated in HIV disease?
Good question. Normally, in a normal individual, the HSV can be treated with acyclovir 400 milligram 3 times daily for 1 week. And in the presence of HIV, we cannot stop the treatment. It may take longer duration till a complete healing occurs. I cannot define 10 days or 20 days. You have to give the treatment. The patient will have signs of healing. You have to continue the treatment as long as a complete healing occurs. Especially, I shown various types of large ulcers and coiled ulcers. In those cases, it may need, the patient may have sometimes need even up to 3 weeks acyclovir. So that is very important. On the acyclovir, or otherwise we can use famciclovir. Dose is almost same. We need not increase the dose. Only thing, duration. And we can also treat with valciclovir 500 milligram twice daily or 1 gram daily. So that's also we can use. But the thing is, we have to use a longer course till a complete healing occurs.
Okay, thank you so much, sir, for explaining it really well, sir, once again. I hope that Dr. Shubhangi has received his answer. I will be taking last question for today's session from Dr. Anupam. He is asking, is hair and nail disorder are associated with HIV disease, or what are that?
I am not able to follow.
Yes, so the question is hair and nail disorder are associated with HIV disease, or what are that?
Yes, any part can be affected, especially nail disorder. I have shown TINEA, that is TINEA, that is a nail infection of the TINEA is also common. And the other things are also can occur, but we need to treat for longer time. And nail pigmentations can occur, and hair loss also be there. And sometimes the seborrheic dermatitis of the scalp exacerbated and hair loss will be there. So we have to treat accordingly. Onychomycosis. So we have to treat the normally onychomycosis. We have to treat for 6 months for hand digits and nails, and more than 9 months up to toe digits. So it will exceed the normal duration in the presence of HIV. And one more thing is, I told extensive treatment for all these things, herpes and onychomycosis, tinea, all these things I'm telling. But in spite of that, when the patient is under ART, when the patient is on ART, and when the patient is having undetectable viral load, and when the patient's CD4 count is more than 500, then the treatment is almost same as that of the individual who is not having HIV. So that's also we have to keep in mind. Only thing, the longer duration and all these things, altered things, and all these things are only when the CD4 count goes below 200 or 250 or 200 or 100, like that only. Otherwise, when the patient's CD4 count is above 350 or 500, the patient behaves as normal, and we can treat them as a normal individual who is not having HIV.
Okay, thank you so much, sir, for answering all the questions, sir. As there is no more question, but I can see feedback from Dr. Shubhangi. She has written wonderful session. Thank you for clearing my doubts, sir. And it was wonderful presentation. I hope that Dr. Shubhangi has really enjoyed this session, sir. As there is no more question from the participants, sir, if you allow, with all your permission, shall we conclude this session, sir?
Sure.
Yeah, thank you so much once again, sir, for giving your valuable time, sir, from your tight schedule, sir. I hope that participant really enjoyed this one, and hope to see you again in future, sir, with different topic. Till then, take care of yourself. It was a wonderful session once again. Bye, sir. Take care.